Okay, I'm going to make an introduction for the camera, and then we can get started. So this is the selection of issues for the NHS England AGM, which will be taking place on the 18th of September, and we'll be using the issues that were in the test of the NHS Citizen Gather phase. So for those who haven't been aware of it so far, we've been testing the NHS Citizen prototype by asking people to come up with issues that they want discussed at the Assembly on the 18th of September. We had 121 suggestions, which have been grouped down to 80 ideas that we'll be going through today. And if you look on nhscitizen.org.uk, you can see both all of the ideas and all the discussions under them, which are at gather.nhscitizen.org.uk. And also on the project blog, you can see the criteria that we published at the start of this process that we're going to be judging them against today. In the full version of NHS Citizen, if it were running for real, this would be a citizens' jury rather than a group of people who've been in some way in contact with the project, but partly because of the shortness of time and partly so that we can feel what the citizens would be feeling in this experiment. We're going to be doing it ourselves, but we'll be doing it on camera, and you'll be able to see why we're saying yes and no to what we're saying yes and no to. There are some people behind the camera who you can't see, Mel, Huda and Susie, who are taking notes and watching us to see what's going on and to watch our interactions. But the three people who are going to be here, I'll let them introduce themselves.
So hi, I'm Olivia Buttsworth, I'm Head of Public Voice at NHS England.
And I'm Sasha Batt, and I lead on engagement and experience in the Bradford CCGs.
And I'm Anthony Zacharievsky from the Democratic Society. So I've got 80 ideas, and we're going to do this in two stages. The first is that we have to filter out the ideas that don't meet the three filter criteria. So the three filter criteria, which you can see online that we posted at the start of this, are the issues that are discussed at the NHS England Assembly have to be within the remit of NHS England, otherwise it's just an interesting conversation and nothing will happen. Have to be of national significance, because a local issue can be of national significance, but they have to be big issues, enough to make it worth the while. And third, they have to be issues that you can thoroughly discuss in half a day, because if they're the future of the health service, well, that's a lot more discussion than there is time for in the AGM. When we've gone through those filter criteria, we will have knocked out some of the issues, and then we have to judge which issues had good quality discussions, and we define what good quality means in that blog post, and they'll be the ones that either on their own or grouped together to form a sort of slightly larger issue, or possibly split into form smaller issues, we'll be using as the 5 issues that go forward. After that, when we've finished our conversations today, I'll be putting up a blog post on the NHS Citizen site that describes what happens next, and we'll be inviting everyone who was involved in the discussions, but particularly people who are involved in discussions on the issues that are going forward to the Assembly, to propose their statement, their thing that they would like the Assembly to hear. And we'll be using a simple voting system to show which of those statements have the most public support, so that when the Assembly and the NHS Board takes a look at these issues in a few weeks' time, they'll have some public opinion, as well as in addition to the discussions that took place so far. So that's what we're going to do. If everyone's happy, I think we can get cracking. So we're just going to look at the issue descriptions at this stage, not the discussions underneath. So we'll start with issue 1 in the community health sector, which was: should more of maternity and children's services be provided in the community? What sort of services and how should they be provided? So the question for us on each of these is it in the remit? Is it nationally significant? Can you discuss it thoroughly in half a day?
Okay, so on that one, I think it is within NHS England's remit. I think it is nationally significant, and I think it's massive to discuss in half a day, but could be a really interesting starting place.
Okay.
And it's whether it can be broken down.
Yeah.
So I know later on we're going to be talking about young people, and the children's services might fall into some of that remit as well.
Yes, I think the problem I have with hitting the third criterion on this one is the maternity and children's services, which is such a huge. I mean, that's enormous.
Yeah.
So I think let's take it through to the next stage as a question mark, and we'll come back to it and see if we can either split it or put it in with a couple of other ideas to turn it into something that works.
Okay.
So, developing a primary care strategy. Pressures on GPs are currently huge, and the large growth in housing that's being planned by local authorities will exacerbate the problem. LA's local authorities should ensure that community infrastructure levies required for new primary care development are requested in the framework of the overall strategy. So, in other words, I think paraphrasing, if you're building new houses, the local authority gets some money as a as a way of providing the public services that those new houses will need. The NHS needs to be better at making sure that primary care development's included in that.
Yeah.
Is that a NHS England matter?
So it falls within NHS England's remit on the basis that we're responsible for commissioning primary care. So therefore there's a direct relationship. And I think it probably is of national significance in terms that there's another one later on around postcode lotteries as well. I struggle with whether you could do it in half a day.
And it's something that needs partnership discussions with local authority partners around the table, because they have an equal responsibility about how housing developments are agreed.
So this is your point is actually the one that I thought probably killed this one off for me, which is that actually although it's an NHS England remit, actually what you're talking about is being more structured about how community infrastructure levies work, and that's something that has to be an LGA conversation as well. I don't know whether people think that's something that it's fine to have a first discussion about it at the AGM and then take it on elsewhere. I mean, one thing I should have said at the start is that none of these ideas get lost.
Yeah.
To say something isn't going to go to the AGM doesn't mean it's going to go nowhere. It may be that there's a better place for this in a conversation elsewhere.
It's probably about having a structured approach that all areas could use to support how they have those conversations with governments, because that's probably what's maybe not people don't have.
So,
sorry, the way
USO
sounds
taking
like
off
it's
noise.
some sort of aeroplane taking off. That's a bit random.
Okay, so I would vote no on this one, and I'd vote no actually on the grounds of NHS England remit, but also on half a day.
Yeah, what I'd like to do though is it is relevant to another one that comes up later on as well. So it might be
we'll come back to it.
The other one that's later on becomes the focus.
Okay, fine. So we'll come back to this issue and see what we can do with it. If we're moving away from issue 3, if we're moving away from hospital-led care to care closer to home within primary care, how will this be sustainable with the current shortage of GPs? What will it mean for patients, carers and choice? I think that's much more than half a day. I mean, I think there's a access to primary care because of GP shortages is an issue, obviously, within NHS England's remit because they commission primary care, and it's a nationally significant issue with the best of them. It's a question about whether that's something you can talk through in half a day.
So there is some work going on at the moment, led by Joe Lenihan and Ian Dodge, two of the national directors of NHS England, about the 5-year forward view, which about what does the NHS look like in 5 years' time, which for me this sits squarely within.
Okay.
Now, whether this would then form a useful starting place for a conversation in terms of informing that piece of work at this point in time kind of feels right.
Okay.
But that's the bucket. I put it into that 5-year forward view bucket,
Right.
and I think there's a few of them that fall into that sort of bucket.
Well, let's take that one through because we're only filtering at this
Yeah.
stage. We'll take that one through to the next stage, and we can talk about exactly what it looks like by the end. Question 4, or issue 4. Most small practice buildings are owned by GPs and too small and unfit for providing more space for more and better services. What are the NHS going to do about it? So is that a 5-year forward plan thing as well? Or is there a capital strategy? Or
There's a whole capital asset work programme, and again it feels GP surgeries are one aspect of community health services. So is it doing something like that in isolation? And actually, is it more of a local issue that directly links back to the one we've discarded around local authorities in section 106?
Because it's also, like I said, it'll be different in different areas.
Yeah.
So is it something about, I think there's probably something running through both of those situations, is how are local areas supported to have those discussions and raise that topic so that people can address them.
I'd be tempted to sift it out at this stage on the basis that it needs to be local conversations, but as Sasha says, with support to have those is the national piece.
Yeah, I think that's right. It feels to me like this is refer it to the
Yeah.
people who are thinking about the capital
Yeah.
asset strategy,
Yeah.
but also think about how you can have these conversations at local level.
Yeah.
So, all right, I think that makes sense. On 5, community cohesion, the asset-based community development model is the way forward for patient-to-public engagement in communities, including rural. So, trying to translate this question, I think it means that it will be, the asset-based community development should be used, and you can spend money more effectively doing that than you can doing traditional services.
Yeah.
To which I think the answer is, that's my prejudice coming out, but the answer is certainly yes. The question is whether it's the sort of thing that is best discussed at the AGM or best discussed through
I
different
think
routes.
there's already guidance in the Transforming Participation Guidance. There's already some documents and good practice examples of how people can do that locally. So I think that work already exists, and then there are examples of areas that are doing that now. So I think that's an issue that has been addressed by NHS England, and good practice has been shared for areas to actually start acting on.
You see, I think there's an interesting point here. I don't want to dive too much into philosophy when we're doing this exercise, but I think that if something's being raised as an issue, the fact that NHS England is already doing something about it probably doesn't mean we shouldn't talk about it. But it may mean that we need to
Promote.
That we need to bring the right people into the conversation so that the conversation is a productive one.
Yeah.
Maybe earlier, maybe in the full version of Gather, that should have mean someone should have been going, I can answer that. That's going to go to the AGM.
So we can answer it. It is in the guidance that we published. The question that isn't described there, but I think the right question is what stops it happening.
Yeah.
So we know that it's the right thing to do. Everybody says it's the right thing to do, but that's not then how we behave and operate.
Yeah.
Which, again, might then lend it to being in the 5-year forward view, because if this is about a remodelling of the way the NHS operates in communities, is an asset-based approach the best starting place, in which case everything builds from there.
No, absolutely, yeah.
So we think this is not to go forward at this stage, or consider it as part of something that we might create a group from? A community development
as
group?
part of a group.
Okay.
And possibly
With the focus
within
on
the
the
5-year
barriers,
forward
yeah.
view. And maybe it's the cultural piece around what stops things changing, what stops practice
Yeah.
developing.
Okay. Number 6. A lot of patients require an appointment today inevitably end up going to an A&E facility just causing problems. So that's broadly speaking the same as accessibility, isn't it? That's the same as question 3, which we've already said we'll come back to.
Yeah.
So I think if we group that with 3,
Yeah, and it
And
comes up
say-
again later as well.
that's a question about access to GP services, which
Yeah.
is clearly, which as an issue is clearly nationally significant, and all of those good things.
Yeah, and going to the right place and knowing where the right place is.
Now, there's
Okay.
a really long one, transforming the way men of working age can access primary care services. I'm not going to read out the whole issue. It's online if people want to look at it from the webcast. But I think it's
Which actually fits into number 3
and I
again.
think it's back in number 3, isn't it?
Yeah.
So I think what we're seeing is the emergence of a group around access to primary care services,
Yeah.
but with some of these particular issues drawn out, and that may be where, if we're inviting people to come back who've been participating in the discussion,
Yeah.
we say actually, here's your chance to make some of these points about mental health and
Yeah.
and cancer in men, some of which are brought out here.
Yeah.
Okay. Number 8 is avoiding postcode lotteries of healthcare. Despite so much work being undertaken by so many professionals in the public to advise commissioners on the delivery of fair healthcare, it seems to be floundering, and there's a serious danger that some people with long-term conditions will continue to be let down.
It's a national and a local issue, isn't it? So is it within NHS England's remit? Yes, for those services which we commission, and in the way we work alongside CCGs, but the majority of those services are commissioned by CCGs. Therefore, it's a difficult one.
See,
Sorry.
I think this is an undiscussable, personally,
Mm-hmm.
because I think that fair healthcare and it is a very difficult to define term, and I think that it seems to be floundering. It doesn't give you enough evidence to go on to say, well, what's the actual issue we're trying to tackle here?
Mm-hmm.
I think you could say, my worry would be that if you took an issue such as you need to have fair healthcare to the Assembly, then everyone would go, obviously, and it wouldn't be a productive discussion.
Mm-hmm.
One of the criteria we have for a quality discussion later on is that you can have different views on it. I don't think you can. No one's going to stand up in the room and say, well, actually, I've been a supporter of unfair healthcare all my life. So, I think it's. I think we probably need to take this one out on the grounds of not answerable.
Yeah, I'd agree.
It's broad, isn't it? Because
I think
very broad.
I think the problem is it's about everything.
Area,
Yeah.
So it doesn't fit the discussing thoroughly enough.
And actually, the broad principle gets picked up later in some of the funding issues that have been posted as well.
Yes.
Which is probably what this is getting at in terms of age profiles and areas.
Okay, care of the elderly. Again, I think this is quite a generally phrased one. So, current indications are that the elderly are badly cared for, significant percentage of NHS money, but the quality of care is generally poor and uncoordinated. Carers are given minimal recognition. Forthcoming amalgamation of social care and NHS funding for this group has not been planned or evaluated. What do we think about this? This feels more like a question than an issue, if that makes sense. Particularly that what is the evidence that supports a positive picture of taking things to the community?
Yeah, so it's not. It's very, very broad.
It's very broad, so you can't see which bits are the NHS England remit and which bits would be local remit.
And so the carers issue that's kind of referenced within it would limit a conversation on about carers to the elderly, and carers clearly have a much more significant role across all age groups. I'm tempted to say actually there's an awful lot of work already going on where these issues are already being discussed in a sort of a post-Francis and everything else world. Therefore, is it of a significant point to talk about at the Assembly, or is it that it's being picked up elsewhere?
I think the problem is that the significant point is too broad because it's about elderly care in general.
Yeah.
And the specific question, is community services going to work for elderly care, is being picked up elsewhere. I think let's come back to it, because I think there is something around community services and transition to services in the community,
which actually goes back to that first issue.
Which goes back to number 3. So maybe we just say that this is picked up as part of number 3.
Yeah.
So that's the section on community services. Funding is the next one. CCG funding approval. It's unclear how CCGs make their decisions on funding continuing healthcare. There should be an agreed format and more transparency. Now, this is where my technical knowledge suggests is not good enough to know whether this is an NHS England issue because you set the rules by which CCGs operate, or not an NHS England issue because it's CCGs who should be being more transparent.
I think it's potentially both.
Okay.
So the rules around funding for continuing healthcare are set out. Somebody can correct me on Twitter or something if I'm completely wrong on this, but I think they're set by Department of Health as opposed to NHS England.
Possibly. Don't know.
And then NHS England has a remit around supporting how they're implemented, but it's up to CCGs to do business. And therefore I would say that it's a CCG issue, and there isn't, in the way that that's presented, there isn't enough evidence around saying that is an issue that many CCGs are facing, which would then make it of national significance.
I'm just typing because that,
Uh-huh.
that made me think about something about our process, which I will write in the notes of the event. That we needed someone who had that level of expertise about what was in NHS
Yeah.
England's remit and not to be part of that filtering process. So I think we failed this on. We passed this on elsewhere because of number one.
Mm-hmm.
But also, as Olivia mentioned, number 2 is that we don't know if this is particular to certain CCGs or whether it's a national significant issue
Yes,
as well.
that's true. Yeah.
So actually, it could be something that the Assembly picks up in future if the gather process gathers more and more evidence that it's an issue facing many CCGs, not just
Yeah.
some.
Okay. Developing and funding gender identity services is number 11.
Yep.
Again, a long one that I shan't read out, but essentially saying need to adopt a less expensive but still safe treatment model for gender identity services, so that the expertise is disseminated within primary care based on informed consent rather than gatekeeping.
Mm-hmm.
Nationally significant?
Yes, it's nationally
NHS England
significant.
responsibility?
Yes, it's our remit.
Can we talk about it in half a day?
So there's been, potentially, yes, there's been a lot of work done already around gender identity services, because this is what I do know about, because my team have led on the engagement processes. And there are some very specific issues going on at the moment that are of massive significance for those people that are affected. So yes, I think it probably is potentially quite timely to have a half-day conversation
There's
about
two
it.
questions in one here, though. The first is about gender identity, which sort of the bulk of the question refers to, but actually the phrasing
Towards the
is
end,
specialised services. So is it worth? Would we want to take it to the next level as a specialised service conversation or a gender identity service conversation?
I think for this SIFT, let's keep it as both,
Okay.
because there's a gender identity question later
Yeah.
that comes in,
Okay.
and there are 2 issues, but it might be useful to focus on a specific service area in order to tease out what the issues are for specialised services more generally, because to do the whole of specialised services in half a day would be impossible.
Okay. All right. So we'll pass that one through. Privatisation of the NHS. How far has it already gone? So I am assuming that this is not the only. I'm looking to Susie here.
There's
not
a
the
couple of
only
other references to
privatisation
privatisation.
reference that we'll come across today.
And there's the TTIP
Yeah, TTIP is something. Yeah,
there
similar.
as well, which is similar. So in terms of the way that this particular one's phrased, I'm not sure it's a question. I'm not sure it's phrased as a question that can be discussed, and it conflates, or it includes within it the stuff around student training and professional development and all of those things, and how that works in what they're saying is a privatised market.
But I guess the other issue they're getting at is about how people complain or raise issues about the NHS, and that not being very clear, and whether that is a national significant issue, that people still are very unclear as to how they can actually raise their voice, which probably comes back to later discussions that are in there about voice and influence.
But it's making the complaints issue specific to private sector providers,
Yes.
when actually the complaints issue is a much broader issue across all of NHS services, regardless of provider type.
Yeah.
I think it's a tricky one because there's a lot of discussable stuff in it, but it isn't quite phrased in a way that
No.
brings out a single issue. I think let's.
I'd be tempted to say, as it is described there and phrased there, it's not a discussable issue for the Assembly. There's kind of 4 different sections in there. One of them is about competition policy,
Yeah.
which again actually rests more with Department of Health than it does with NHS England. There's one around complaints, which I think is a separate but related one. There's one around the assets, which goes back to the earlier one around GP buildings and facilities. And there's one around training and development and how that works in a marketised healthcare system.
Yeah.
So it conflates too many things or puts too many things together to be a discussable issue.
Okay, I'm happy to say that this doesn't get through the filter on it not being a discussable issue and therefore not being something that you can think about in that way.
But the things need picking up.
I'm slightly sorry to lose what's an important issue that has come up in several discussions. But anyway, I think it's not. We can't. We have to go issue by issue, and then hopefully something comes up later on that meets the requirement.
Yeah. Okay.
Okay. So level of funding for primary care, I think, is pretty much squarely in the shortage of GPs back in number 3.
Yeah.
Cost of very senior management in NHS England and elsewhere in the NHS. So, who's responsible for setting NHS England's senior management budgets and salaries? Is it NHS England? I suppose it must be at some level.
Well, it's not, because it's all agenda for change and NHS employers.
Oh, is that right?
And union negotiations and all of that. So NHS England doesn't have control of setting national paying conditions. It's a part of the NHS, and those terms and conditions apply to the whole of the NHS.
Workforce,
Oh, so in which case...
So it's not an NHS England specific.
Okay, well that's simple enough.
The cost of it might be, in terms of...
Yeah, but if it's something that the NHS England board can't make any decisions about, then we can't. Then it's not worth discussing. Well, it's worth discussing, just not at the NHS England board.
They can change the staffing structure, so they could. So that it's within NHS England's gift to determine what posts they have, but it's not within its gift to determine their terms and conditions.
In which case, I think this is better discussed, better passed on to NHS employees.
The question here is how the structure. The concern is what the structures are.
Yeah.
It's not so much the pay level is decided by the external body, but the structure would be decided internally.
If we want to push it on and take it through and think about it
I don't
further.
think it'll be discussable in half a day.
No, and it's if what the discussable issues are the functions that those posts are delivering, as opposed it's. I'm trying to think how you'd have that conversation.
I don't see. This is my point about it. I think being something that's. I don't know. I can see
that conversation happening already, though, with the cuts and plans happening. So actually, this conversation and consultation with people affected, like staff members, is taking place.
Yeah. And so actually, and there will be board papers that are presented on what the future looks like. So actually, we could say that this is being addressed already, and will be picked up through the public board papers as those changes are implemented.
Interesting. I think that means that what you're saying is that we ought to. Actually, I think that means that we ought to say it's possible. It's an issue that you could discuss, but actually, if there are other things that are coming up.
Yeah.
But you think it can't be discussed in half a day?
Well, it depends on, because that work is at the moment ongoing. What comes out of that with the evidence and the actual issues, then actually it might be something at a later date that is discussed in half a day.
Yeah.
But not for the September.
And as it's set out there, actually it's talking about the costs of very senior management, which would lead you into a conversation about how pay terms and conditions are set for the NHS, which is out of the remit of NHS
I still think it's not in NHS England's remit. It's not wholly in NHS England's remit. So I think this is something that you pass on to NHS employers on the salary structures, and that you pass back to but that you pass through a different route for a response that comes on the work that's going on restructuring and cost savings.
Yeah.
So 15. Area teams are no longer providing funding for new GP practices as a result of property development. That's back in 3, isn't it? It's in fact almost exactly the same question.
Yeah.
Section 106, yeah.
Oh no, there's the GP surgery one, which was number 4, which we've discounted, or not just, we've said we'll refer it on to whoever's running the capital assets programmes.
Ah, yes, okay.
So I think it goes in with that.
Okay.
Yeah.
Yep. Okay. No, I think that's fine. It's part of the same. It's part of the same issue. 16. Withdrawal of MPIG funding.
Yeah, I know what MPIG is. Let me just. I've got it written down somewhere. I had to ask. Beverly Bryant, thank you very much for telling me on the train this morning. Medicines, Pharmacy and Industry Group.
It's minimum practice legal guarantee, which is...
Beverly, you were wrong.
There are too many MPIGs in the world.
It's about GP surgeries used to have what's called a minimum practice income guarantee, which meant that, I don't know the details of GP funding, but what meant that, like, for example, small rural surgeries had their income topped up to a certain level. And with the changes, and a bit more detail probably needed, but this is gradually being withdrawn, it's being stepped down, and it will eventually go, and particularly small rural practices will be threatened by it.
So I think.
So it goes into
But
3.
the variety of duties practices will be threatened by it, particularly small rural practices.
Yeah.
I think it's part of 3, and I think one of the things that this is throwing up for me. Thank you, Susie.
Yeah,
I think one of the things that this is throwing up for me is that the 3 is turning into what started as 3 because it was the first one we came to is turning into quite a big question on access. So I guess one of the things we'll have to think about later on is exactly how we phrase that to include the different elements of it. Whether it's like, access, 5 or 6 bullet points reflecting the questions and asking people to make statements on that.
Yeah.
Which I think you probably get something out of.
Yeah.
It's just a question of working out how we do that without losing the individual contributions that have already been made.
Yeah.
So
Great.
17. How can public funds continue to fund everything the public and patients expect of NHS, and how can funding be prioritised? Well,
So you're paraphrasing, sorry.
I am
thought I was reading
paraphrasing.
something
How
else.
can we afford our NHS is the title of the question.
Okay.
Present funding cannot keep up with advances in technology and medicines. We benefit from a community-led discussion about how public funds can continue to fund everything the public and patients expect of the NHS.
This is an interesting one because when we were doing the call to action, it was one of the very key themes that was discussed, and people have very, very different views on how the future of the NHS can be sustained.
And there's a piece of work going on at the moment around prioritisation and what's the framework that we use to consistently apply fair and equitable methodologies to how we prioritise and make those decisions. So I think it's a good question. I think it's one that it feels like we ought to be keeping it in, but it also feels very huge.
Yeah.
So can we keep it in with the
It
question
ties
mark?
in a bit with the specialised services.
It does.
And
Don't forget, we're only filtering at this stage, so let's keep it in for now. I'd like to kind of, if we can rattle through them quickly, and then we can have a longer discussion about the pros and cons. Training patients and public to be lay representatives. Many people attend groups and committees ostensibly as lay representatives and are unable to make an effective contribution because they do not understand the bigger picture. Some are there because of personal issues and some are there so they can impress their friends. I'm not aware of any validated education programmes. Education for lay representatives.
So, yes, it's something NHS England has to think about, and that falls actually within my team's responsibility. I think it is nationally significant because whatever we do nationally,
Okay, sounds like it goes through to me.
I think it'd be useful. I think there's other ones that we might throw
And
into
it's
this.
discussable. So, okay. So, 19. There needs to be more collaboration between patients and the NHS so that patient records are accessed and updated by both. Feels like a yes to me.
I think it's definitely yes.
Yeah, okay. Supporting people who have barriers to participation in usually communications difficulties, we need to ensure the unheard are heard.
I do wish they'd put a longer description on that.
I think that this is just again a yes. Everyone would agree with that.
Yeah, it is. And actually, there is very specific work going on at the moment around the Accessible Information Standard.
Yeah. 21. People without access to computers are left out of decision making about themselves because of lack of knowledge about their conditions. They also don't get full information about the practice and its services and need access and knowledge of the internet for other services such as benefits applications and local government services. So I think that what this means is like social media and IT, internet training and digital skills training for patients.
Which would link directly with patient records.
Okay.
In terms of online access to your record.
All right, so should we group it with 19?
I would group those two together.
Okay. So, 22. Choice versus safety. People seem to have made the assumption that we want to choose where we are cared for when ill. that we should be offered choice along the patient pathway following extensive experience of receiving care in the last 3 years. I can honestly say most of the choices offered to me were false, and it felt more like a surgeon passing the buck than me choosing what was going to happen.
Yes, I think it meets the filter.
Okay, then
I think
let's talk about it
yeah,
later.
I want to talk about it in relation to some of the other ones that come in later as
23, involvement of patients in management of their own healthcare. Because patients are more involved in a truly active way in the management of their own healthcare, especially in the case of chronic conditions, the better health outcomes and the more the benefits to patients, but also the more the savings to the NHS.
Mm-hmm. Yeah.
Is that a yes?
Yes, I think it's personalised care planning and personal budgets, and actually the choice versus safety one falls into that.
Yeah. Patient involvement at board level. There's not enough general public patient involvement or say on how services are being delivered, despite NHS England's policy to be more open and transparent. So this is an interesting one. I mean, I'm assuming that appointing a patient onto the NHS England board is not in the remit of the board, because the board don't appoint themselves, do they? They're appointed by the Secretary of State.
The board, yeah, so the board are appointed. The NHS England has a number of non-exec directors who bring a number of patient and public perspectives to the board. I think there's a wider issue which is about patient and public voice influencing, which is actually better phrased by another issue later, I think, if I remember rightly. So I'm not dismissing the issue, but does appointing a patient to the board actually solve that issue, or is it then viewed as another tokenistic attempt to say there's our patient representing 55
have
million
to say that 24,
country.
25, 26 and 27 are almost the same issue repeated in 4 different ways.
Yeah.
Yeah, so there's patient and public reps, engagement and involvement, patient views, and going beyond consultation.
Yeah. Which we could group and have a really useful discussion about what makes for effective voice and influence
Yeah, I think
of
that
the
seems
public
like
in the NHS.
That's a broad issue, yeah.
As opposed to limiting it to say you've got to appoint a patient to your board. Which patient? What condition do they have? Sorry, I'm quite cynical about that.
About what?
Appointing patients to a board.
Oh, well.
There's a bigger conversation to be had about what good looks like and how that how that voice influences and how the NHS hears and acts on.
Okay, well, if we group...
Which, if we group those together, we could have a really useful conversation.
Yeah, if we group 24 to 27 together.
Yeah.
Because 25, just for the record, is the influence of the public in the way services are run should extend to their involvement in monitoring and evaluating the changes they want against a background.
Yeah.
A long-term role, not just in representing, but in feeding back the results.
Yeah. And actually
26
these
was-
connect back to the asset-based community development
Actually, they do.
issue as well. Because
They
if
do.
you're working in that co-productive asset-based way, then your influence and voice it is embedded and integral throughout.
Okay.
And the training one, which we've got
Yes.
To that other question, yeah.
Yeah, sorry.
Safe hospital discharges. This is local hospitals here. Item 28. This is a personal issue, but talking about unsafe discharges which resulted in complications in my condition and many follow-up admissions, which has obviously cost the NHS more than keeping me in for one extra night to make sure I'm safe to go home. Failed discharge delayed my recovery and cost the NHS more. If my discharge was safe, I wouldn't have had complications. It would have cost the NHS less. Is this how does NHS England work on this? Is it a standards issue, or is it really for the trusts?
I think it's for trusts and CQC in monitoring quality and so on.
Okay, that was I suspected that would be the case. So it feels like this is a CQC and trusts.
Yeah.
Yeah, pass the issue on to them.
Yeah,
Unless
it's a
it's a
commissioner
specialised service.
Yeah, it's a commissioner responsibility because you need to be able to manage the quality delivery against the contracts that you hold.
Yeah.
However, there's also clinical issues. I don't think it's squarely within NHS
No,
England's
I think
remit.
absolutely not. I think not, particularly since it seems to be a single. Yeah, there are other experiences that are further down.
Yeah.
But I think there's something.
So the other significant thing on this one, sorry, I've just remembered, is that Health Watch England are specifically looking at safe discharge, and they've got a specific inquiry into that at the moment. So I think this is one that's better cited with Health Watch England, and that's they take that forward in terms of that inquiry that they're already delivering on.
Okay. All right. So, like with all of these issues, we'll pass it on to the right place, to where we think the right place is.
Yeah.
And we'll keep a record of it so that we can see whether when a response arrives.
Is there something also about how we share good practice across the board? So, because this is a local issue, or it could be a local issue if it is trust-based, and there might be some trusts who are doing very good safe discharge, how we share that practice so that it's available wider.
Yes, I think there's definitely something about that in there as well.
Mm-hmm.
Just to pause for a moment. The coffee behind the microphone is taunting me.
It's going to be
Unpaused, undrunk.
So if anybody's watching, do you mind if we have milk, please?
Black thanks. Right, while that happens, 29. All NHS providers should be governed on the Foundation Trust model.
And now I'm going to have more water.
I don't think this falls within NHS England's specific remits.
Okay, I think that's probably right.
It'd be a really interesting conversation, though. But I think it is Departments of Health.
Yeah. I think it's such a big structural
Yeah.
issue. That, yeah.
Yeah.
Okay.
Sorry, I'd love to talk about that.
It's a great conversation to have.
It is.
30. At the moment, the NHS is too diversified and there's no overall thought about how continuity of care can be achieved. Patients with many conditions are pushed from pillar to post, which costs lives and the NHS money. Restricts what the NHS can achieve due to consultants and others attending unnecessary appointments. Those with multiple problems should be placed under a new type of pathway and seen by a specialist person who can then see the whole problem and decide their requirements quickly. How much is the NHS involved in that side of things?
So
NHS England involved in that side of things, I mean.
it feels to me that ought to sit with personalised care planning,
Integrated care.
integrated care ones, of which we have a number of already lodged, as opposed to picking that up as a specific one on its
Okay.
own.
So a group with personalised care.
Yeah. Yeah,
Lots of, I mean, you can
there's loads of
lots
comments
of good
about
discussion
it,
about
which is
it.
great.
So I think we should think about how we can.
Yeah,
Because personalised care plans are just NHS, or are they NHS plus social services?
they should be personalised around the
Should be
person.
both. Yeah.
But we lead on, so Luke O'Shea and his team are leading on the development of what that looks like, and so there's a whole load of stuff that NHS England is leading on, which that would all fit very squarely within.
Okay, so we'll come back to that as
Yeah.
part of the personalised care work. Transatlantic Trade and Investment Partnership, TTIP.
Yeah.
If the NHS is not taken out of the Transatlantic Trade and Investment Partnership, it will mean the final breakup of the NHS and take this country back to the days before our health service was established. Private profits should not enter into health. And then there's a link that people can see on the website to a BBC article.
So I don't think that sits within the gift of NHS England. I think it's a wider government.
I think it's political. Yeah, it's
issue.
the Secretary of State
Yeah.
who has to handle that, which is, but again, an issue.
It is.
And we'll pass that on to the department. for
Yeah.
that. Increasing the quality, 32. Increasing the quality makeup of the NHS workforce and leadership. Makeup of the NHS workforce at senior and leadership levels is not diverse and does not reflect the communities that the NHS serves. Evidence indicates that a clear link between having a diverse workforce and better health outcomes for patients. There's a moral and a legal case for increasing the diversity of the workforce at senior levels within the NHS. So, recruitment and selection.
So I think it does sit with NHS England,
Okay.
and specifically the Equality and Diversity Council, who've got workforce flagged as a specific issue.
Okay, so we want to take it on. Okay, 33. How to upgrade hospital booking system. Cancer department is unable to promise and practice that operation will be carried out within 1 month after diagnosis. I'm not sure whether there's a specific one or whether it's something that this poster would like to happen. All investigations are speed up this target. Patients don't need to ask or worry with writing complaint letters to PALS. Cancer department. So I have to say I don't think
Does this fall into that specialised service?
I think this is somebody saying about how fantastic their cancer department is.
It does read
It's a
like
good
that.
practice.
Yeah, it's a good practice one.
In which case I don't think it
I
is.
don't think it's discussable. As in, it's something that you could use as an example of good practice,
Yeah.
but it's not for
They're
a...
saying this is all possible,
Yeah.
but I don't think it's for the Assembly.
Improving NHS services for people who are disabled and vulnerable. It's clear that although there have been some improvements, there's still more that needs to be done. Care on the whole needs to be better policed and much more needs to be done so that services in the NHS start to look at patients more as the big stores look at customers. If the professionals working in NHS services deliver care to patients like big name stores serve customers, I'm not sure my experience of big name stores necessarily, but anyway, moving on, then we will be on our way to the making of a better NHS. So this is an interesting one. This is about a really tricky combination of issues around access and around records and around data and understanding and patient
And also
centricity.
respect and dignity and
And
how people are
communication.
treated.
So I would say it goes back to personalised care. Or maybe I'm mistaken what personalised care is about. Because it feels to me like what we're talking about here is something that's patient-centred.
Yes, I think there's a relationship with that, but I think there's some issues later around compassionate care and communication within healthcare that this sits in more strongly. So can we just park it for now?
Yep, we'll come back to it. Discriminatory practices regarding the treatment of transgender people is 35 of the 80 issues we've got to go through. Although there are 3 groups within NHS England, technically they have not been formed to look at the overall treatment of transgender people within the NHS, so particularly in primary care, inequalities of treatment still exist between cis and trans people. As this is not a priority, it means that discriminative practices are continuing and are allowed to continue.
So if the other issue around funding of trans specialised services goes through, I think this could sit within that in terms of people's experiences of the NHS
Okay.
as a trans person.
Okay. So that was
So we pick it up within that.
number 3. The
Yeah.
access issue.
It wasn't number 3.
No, number 3 was something else.
No, it wasn't number 3. It's... Sorry. I haven't numbered mine. It's on page 5. Number 2 on page 5.
Second one on page 5. Okay, that's number 11.
I think it goes with that.
Yeah, okay.
It's also about equity.
So, equality for all irrelevant to postcode and savings. We had a postcode lottery one as well, didn't we? I'm aware of some who are getting substandard support and care as a result of their postcode, and if they have savings, then it's not equitable. Take the personal element out, but it's also not an effective use of resources as there's no plan for admission avoidance or support for the carer, etc. I think this is an access issue, isn't it?
I think it's an access issue.
So I think it goes back
I think
to
it
3.
goes back to number 3.
So, 37. Genomics in the NHS, and a service model fit for the 21st century. Simon Stevens announced in June we'll be consulting on moving to a new model for regional genetics labs to upgrade and industrialise NHS capabilities in this area. What does this mean for the public? How will stretched primary care services cater for this new industrial scale of genomics in the NHS clinical care model? What will be cut as a result? The changes being implemented now will change not only the model of clinical care, the decision making about care in the future, but also shape society in ways we may not predict today. Before the decisions are all made, we should be finding out what it means and how we can be informed in the future. And there's a link to a blog post. So, genomics.
Yes, it's NHS England remit. Yes, it's nationally significant. Is it possible to discuss it in half a day? I think it'd be a good
Doable.
start of a conversation.
Yep, okay, fine, so that goes through. Standards for consistent application of continuing care. Consistent standards need promoting across the country as the discussion develops about the nature of health and social care and how we fund them.
Does that fall into the integrated care and
Yeah,
personalised
I think
care?
it's an integrated care one, and it's also a bit of a...
Yeah.
It's another one of those questions that everyone would agree to. CCG engagement at local level. Now, without reading this, Are you responsible? Is NHS England responsible for CCG engagement at local level, or is it the CCGs that are responsible?
CCGs are responsible,
Okay, so I think
and
that-
we've issued guidance,
okay.
and we're there to support. But it is an issue that they need to pick up locally.
Okay. In which case, I think that has to be
Yeah.
not an NHS England issue.
Yeah.
40. Upscaling peer support and making it an integral part of NHS commissioned pathways, because that's what people want at diagnosis and crisis stages. It also acts as a vehicle to self-care and collective involvement, pulling lived experience into the system, which is the most underused resource in the NHS. Friends and families and whole local areas will join in if they see meaningful activities and clear decisions evolve from that lived experience. So, yeah.
So I think it goes in with the personalisation, integrated care conversation, because peer support is an element of that.
It's funny you should say that, because I had it in my head that it was part of the asset-based community development. If you think about communities as communities of illness rather than communities of place.
Yeah. So it could be both.
It could be both.
Yeah.
But I think it goes through, and let's work out exactly how we fit that into a conversation.
Yeah. Just because I've noticed it,
Yeah.
can we flag for process stuff the last comment about why can people not immediately see posts from others?
The short answer is because we were using a system that we won't be using for the full version of Gather, and the reason that we were doing that was because it was what was available and could be put up quickly. Because we were doing it in that way, and we don't yet have a community of people who will self-moderate.
Yeah.
We had to pre-moderate some posts, and so you couldn't immediately see.
Yeah.
You couldn't immediately see everything. So that was why.
Thank you.
Involvement of the third sector in NHS delivery. Many people are unaware that there are local community organisations in their area that they can access for services, and it's a website that you can use to find local community organisations. Again, I think it's asset-based community
I
development.
think
I was
it's
gonna say that.
I as an ABCD, but absolutely.
Yeah. Okay. So 42. Ensuring all NHS organisations are proficient with a personal demographic service. I'm going to spit some acronyms out now. NHS Spine Services, SCR, ETP, C&B, all require the PDS to be synchronised within GP practices. So, the PDS, the Personal Demographic Service, I don't know, in honesty, what it is.
I think this is a training and development issue about how the NHS uses the tools that are available to it.
Is that?
I don't think
NHS
it's an NHS England's only remit. I think it links with Health Education England, it links with the Information Centre.
Okay. All right. In which case, we think it's not an NHS England issue. So we'll pass it on.
Not
elsewhere.
solely.
No. So continual quality improvement is the key. Is number 43. Is the key to improving health and well-being outcomes, valuing staff and their contributions, reducing waste and ineffective activity. Citizens require assurance that quality can be improved within the available budget.
It depends on the service.
Yeah.
I don't think it's I think quality improvement as a whole is not really discussable. That's the problem for me with this.
I don't think it's discussable. I think it's yes, of course, everybody agrees, but
Yeah.
it's not a discussion.
Okay, that's fine. I agree with that.
Okay.
Long-term strategy. It seems that the NHS repeatedly tries out new ideas without checking them out fully first. Introducing something and then asking others what they think of it is not the right way to do it.
So again, I don't think it's discussable. I think it's a how we work question, which actually will we be modelling some of this at the Assembly in terms of having those conversations?
Yes. I think it's not a discussable issue.
No.
What do you think, Sasha?
It's kind of almost saying saying the same thing and then reversing, so that they're saying that we just try out new ideas without checking them out, but then we do check them out, and that's not the right way to do it. So
Yes.
I'm not clear what
I think it's not
is.
I think it's not discussable.
Yeah.
So, bureaucratic and technological inefficiency. It slows down what we do and takes away extraordinary amounts of time that would be better spent delivering good clinical care. The most measurable is not necessarily the most important, which is not to say there should be no monitoring and confirmation of good care, but there is a balance that is currently not quite right.
think this is an issue that's across all organisations, not just NHS England.
Yeah.
It's CCG, CSUs, all of them are facing this.
Yeah.
How do they balance that? And it's an interesting discussion to be had, but maybe not a half a day discussion. And
No, and I think it's
an
I think it's so
internal
general.
mechanism.
I don't think it's actually. Maybe one of the things that we should revisit when we do this again is that criteria about NHS England remit might be, or might be that actually it is specifically about the NHS rather than bureaucracy.
Yeah. Yeah.
Managing change through the system from national NHS England through to providers. Managing variation out of the system is one of the NHS's key objectives, and effective change management that takes national policy right through to the coalface is essential for this. So, change management?
So I actually think at the moment that's mostly led through NHS IQ.
Yeah, I was going to say, I don't think it's NHS
I don't
England.
think it's an NHS England only.
IQ is
Sorry, NHS
Innovation.
Improving Quality.
Okay.
Yeah.
So, and there is a specific change programme as part of that, how you do that leadership for change.
Yeah.
Because I think that goes back to them.
Sorry, that's me. Buzzing away down there.
Okay.
Okay, 47. Use of patient data. NHS England should be listening to patient views on how data is used in programmes such as care.data. I think that goes, for me, that's nationally significant. NHS England.
Yeah.
Yeah. Okay.
We're doing a workshop on Saturday morning if anybody in London wants to come along.
Do you want to pitch the details?
Queen Street Neighbourhood Centre, but we need to know you're coming, so email us. Email me, Olivia Butterworth at nhs.net.
Or hello@nhscitizen.org.uk, which Susie can
Yeah.
forward on. Okay. 48. Ensuring equalities is central to NHS England. Equalities must be central to decision making in health and social care. This is the relationships and transparency sector.
Sorry,
At a time when inequalities are growing sharply, governance and senior staff profiles in health and social care should reflect the communities served, but they do not. There should be more requirements for action to address inequalities before funding or accreditation is given, and there should be democratic accountability to citizens on performance on equalities.
I think it meets the criteria.
Yeah.
Okay. Communication, number 49. Communication between organisations and
Oh,
significant.
just sorry, can we link that back with the workforce
Workforce
diversity
one, yeah.
one as well? Because I think that bundles together quite nicely.
Okay. Communication between organisations and significantly improving the standard of face-to-face care in hospitals, especially from nurses. Everywhere you go, people discuss the lack of care their loved ones receive in hospitals. I truly don't believe it's underpaid and overworked as courtesy and care and cost nothing. Nurses are at the heart of our NHS system, and we put a lot of faith in them. I'm summarising slightly because it's quite a long one. To keep our families comfortable when feeling at their worst, nurses need better training and social skills.
So I think this links back with that one around
Workforce.
improving NHS services for people who are disabled and the vulnerable,
Okay.
around customer service,
Okay.
which is number 3 on page 21.
Yeah.
I should have numbered them, sorry.
Sorry. Number 3 on page 21, which is 34. Okay. So, 50. Basic performance statistics. For some medical conditions, the NHS publishes lots of statistics. For example, if you suffer from an anxiety disorder, you can find data on how well that kind of disorder is treated both nationally and in each CCG region. But if you suffer from an eating disorder, the equivalent data is secret, even though the NHS England directly commissions specialist eating disorder services for most severe cases.
I'm questioning whether this ought to go into the care.data conversation if it's about using data that's essentially contained in our
I don't think
personal
it's
records.
quite the same as care.data though, because this is about performance statistics rather than personal records. So I think
I guess the issue though is that with an eating disorder service, it's a specialist service and it won't be CCG region. And if you did break it down to CCG region, you
Becomes
run the
patient
risk.
identifiable.
Yes, run the risk of identifying patients. So you would. That's probably why.
so. Are basic performance statistics are eating disorder statistics secret?
I don't think they're
I
secret,
doubt that
but I
they're
don't think they're
secret.
They're
broken down
published
to
at national
CCG
level.
region.
Yes.
There might be what used to be the old Essex. It might be a specialist area region.
Okay. Oh, do we?
So it's why I say it's part of the care.data conversation, because those performance statistics essentially are driven from the data about individuals' care and outcomes.
I think we can certainly group it with data. I think the question is then whether we've made the data conversation too broad.
Yeah. Okay.
Come back to it. 51. There are currently 14 million people in the UK living with persistent pain. This is educational pain, self-management in the community and internet. A rise of 7 million since the previous national pain orders 6 years ago. To date, there's little evidence that there's any educational pain self-management, both in acute primary care or on the internet. I hope this is put on the agenda at the NHS AGM. I guess it won't, as pain isn't deemed a priority within the NHS, and yet it's the most reported daily health problem in GP surgeries.
Does this fall into the self-care, integrated care, because it is about self-management of pain?
And how professionals support that.
Support that.
I would agree with that.
Okay, we can group it in that way.
Yeah.
52, urgent and emergency care. What could the NHS do to help citizens decide where the best place is to go to address their urgent and emergency care needs?
There's another one earlier about something.
Yeah, there was. Where's the beginning?
It was the GP appointments one. So
But it's the
patients,
same issue about
Yeah.
urgent and emergency care.
you end up going to A&E because
Yeah.
you can't get GP appointments. How do we communicate?
So there's work going on at the moment about the major emergency centres that have been proposed. So it is a national issue.
Yeah.
It has got national significance.
Yeah.
But it is a CCG remit because they fund the hospitals to provide urgent and
But
emergency care.
this is about citizen education around how do you decide where the best place to go is. So do you ring 999 111? Do nothing. Which I think is
National.
an NHS England remit. I think
Mhm.
it needs to stay in.
Okay, fine. Always happy for things to stay in.
This is really hard. I just say that like this is really difficult.
I think that's one of the things that's one of the things to learn from this process, and the reason that we're doing it ourselves is to see how hard it is. And certainly there are things here where I'm going, well, if I was a member of the public, I'm a member of the public, but if I was,
Only a member.
if I had
No role within.
no knowledge at all about how NHS England works, I'd be going, well, I don't know, is it NHS English?
Yeah.
I think
A lot more than that.
if we were doing this in public, we would have to put a lot of briefing in, some background briefing in about
Yeah.
things like that, because there's no way you can look at some of these issues cold. I don't
No.
think so.
No, I think that's true.
Or there's something about having access to specialist advice through that process.
Yeah,
Yeah.
no, that's right.
What was the time period on collecting on the gather?
Oh, so quick.
Yeah, pretty quick.
August.
So if we had then
No,
a
not
full
even,
year,
not,
we'd
not
have...
even, not even that.
Yeah,
I mean,
not
we're
even
talking
that.
in terms of issues. We gave people 16 days, something like that.
Yeah.
And we had 121 issues that we grouped down to 80.
Yeah.
Now you can see they're going to be grouped down further. And one of the questions that, anyway, it's a conversation for another day. One of the questions that this brings up for me is whether really these groups are actually rolling conversations about access and rolling conversations about integrated care and so on, and actually that creating lots of individual issues doesn't necessarily give you a proper picture of what the because it's just someone's take on a thing. And actually, if you say, well, here's a group of issues, and there are 30 groups of issues, and we'll take 5 of them at each assembly, and you get people to get involved in the conversation there. That's a different way of doing it. But
Yeah.
anyway, it's worth thinking about for the next bit of development work. Right, 53. Accessible information and communications technology for all. We've kind of had this one before as well. The NHS is going paperless, patients are being encouraged to go online, I won't read all of this out, but accessible IT so all can benefit while clinicians, managers and patients begin to understand and respect each other as they realise the common ground delivered by highly overlapping and accessible ICT.
Mm-hmm.
Personally, I think this one goes ahead.
I think it has to stay in. The only thing I'm questioning is the role of the Health and Social Care Information Centre. But we can pick that up.
Yeah. 54, publishing headline data. Education of the public by the NHS and not the media. Communication with the public about the services, the number of patients and the associated costs need to be published in a format that's easy to understand. That's the data question again, isn't it?
It's not just
that.
data, it's how we communicate question as well. So communicating, and there is something, I don't think we've got to it yet, there is something about recognising the fact that 7.5 million people don't have basic literacy. How do we communicate what are fairly complex issues in a way that they can understand? And so this is, for me, this is saying that this needs to be done as a public education process by the NHS and not by the national media.
That picks up on an earlier question where
does.
somebody was talking about how it's perceived to be elderly healthcare is very poor, but that's because it's a media reported thing, and actually the instance reports are going higher because actually maybe Francis is allowing issues to be reported, but that's how the media reports it rather than what the actual cases.
So I think it does need to go through. I think it might group with some other ones once we get.
Okay, that's fine.
through.
As long as it's going, if it's going
I
through,
think
it's going through.
yeah.
That's good. Treatment and services, health literacy. Oh well.
Oh,
As if by
oh
magic.
look, we turned over.
7.5 million adults cannot read and write at a functional level, and even more have problems with numbers. This means that people don't turn up for appointments, don't follow medication instructions correctly, are unable to explain their symptoms in detail, and don't understand how to use services appropriately.
Yeah. So this connects with so many of the other issues as well that we've talked about. So it might be that this becomes a cross-cutting theme into a number of the other issues.
Yes.
Possibly. But
Yeah, it's possible. Yeah. Okay. 56. Therapies. We need the provision of vital therapeutic help for the autistic, those with stroke and those with dementia. The need is for intensive therapy exactly at the point of need if it is to be effective. I'm not going to read the rest, but it's quite a long one. So, therapies is not quite the right title, perhaps. It's really about therapeutic support for the autistic, those with stroke and those with dementia.
Mm-hmm.
I have to say
CCG commissioned services.
I don't quite see what the issue is in it.
I think this leads at the beginning there was the thing around specialised services and different models of services, and how we look at how to develop new models of providing services. So this is about looking at intensive therapies, which at the moment aren't provided for these services.
Yeah.
So how do we trial new? It was that one about maternity and children's services at the beginning.
Yeah.
Looking at how do we trial new types of services.
Mm-hmm.
Rather than going always with the traditional models of care.
And we haven't done the early intervention ones yet, have we? But they come a bit later, because this is about having the right therapeutic interventions at the right time, not ending up. So stroke being a great example of you need it really early to get the best outcomes, but often it doesn't happen.
So do we think this goes through, or do we think it's not discussable? My instinct when I read it was it's not really a single issue here.
I don't think it is a single issue. I think it's complex and fits with a lot of the other ones, and maybe we just bear it in mind when we get to the early intervention.
Okay. All right.
Ones.
I think that makes sense. How can NHS England support carers better? How can they improve the way in which we care for people? What needs to happen to turn this into a reality? What would make a real difference to the lives of people being cared for and their carers?
So I think this definitely goes through. We've got a carers
Discussable
strategy.
Then?
Yeah, I think it is discussable.
Sasha? Can we get through this in half a day? That was my concern.
This is about what support carers need. It's not disease specific, which would make it huge. So it's the broad aspects of what support is needed, which I think is discussable.
Yeah, I think it is.
Okay.
It is big. I'm not, but I think it's also hugely important.
Right. 58.
5.5 million carers,
Number and so on.
something like that.
So 58. Proposals are currently being discussed in North Staffs to decommission hearing aids for the people who most benefit from them, or for most people who benefit from them.
So this is a
It's
local issue.
It's about a particular CCG decommissioning a
Yeah,
service.
I think it's not a national issue.
It's one of the discussions where it can go into it being a little bit more general.
A bit further down they do. But I still think that I don't know whether this is a North Staffordshire specific issue.
Yeah,
That's the thing.
there
I don't
is-
think there's any wider proposals. So it feels like if it was something that was really showing up a huge problem, then a local issue might be nationally significant. But if it's one CCG taking a
Yeah.
decision that's out of line,
Yeah.
it has to, we can pass that on to the CCG and say this came up to us, but
Yeah.
not, I think.
And actually going back to the Health Watch role in this whole system, actually passing issues like this on to Health Watch, so that
Yeah.
because they're monitoring and collecting issues that are emerging from their local Health Watch network, they'd be able to really quickly sense check through the
Yeah.
local Health Watch network. Actually, is hearing aids something that's bubbling away?
That's right. And I think the risk of not doing that is that NHS system becomes an appeals mechanism
Yeah.
for local issues.
Yeah.
That the board gets to, people trying to push everything to the board. And that's what we don't want to happen. Okay. 59. Nutrition awareness. Poor nutrition is associated with a significant amount of NHS caseload.
It's public health.
Yeah.
Yeah, I think that's right. 60. Health inequalities. It's in the Constitution, but the infrastructure to support change is weaker than ever.
So as it's phrased, I don't think it's discussable.
I think it comes back to some of the stuff on access earlier on. I think,
I think it links into the asset-based approach work about infrastructure and making sure you're connecting to the right people to address health inequalities.
from my perspective, we will be talking about health inequalities. It's just that we don't necessarily.
But not
I think we don't.
necessarily
I think
because
this
that
isn't
one
discussable
is-
as it's phrased. 61. Dealing with obesity. What do we need to do about it? There's an obesity crisis in England. What needs to be done to deal with this?
Clearly, Simon Stevens wrote an article in the HSJ recently about
Good.
obesity.
What did it say? I didn't read it.
I can't remember without being slightly flippant. It's about
Okay.
chips in canteens.
Right. Fair enough.
It was more than that, but actually, we do need to do something. So,
I mean, it feels to me like this is straightforwardly an issue that can go through.
yeah,
So. let's
yeah.
leave it at
I
that.
suppose the question in my head is, it's also a Public Health England thing. However, NHS England can provide some leadership in providing a
That's a good
space for
question.
that discussion.
That's a good point. All right. Well, let's come back to that. I think let's put it through for now.
Yeah. Okay.
Common mental illnesses, IAPT. National Improving Access to Psychological Therapies programme to provide treatment for the commonest mental illnesses, depression, anxiety disorders, and centrally managed within NHS England. Successfully treats only about 1 in 8 of the people referred or self-referred.
So it feels like it's just making a statement about IAPT
Does a bit.
as opposed to providing an issue for discussion. And actually, would it? The IAPT would come into a number of the other ones around mental health that come up later.
Yeah.
So I think, as it's phrased there, it's a really difficult one. There's nothing that. Yes, it's interesting information.
But are they saying that because it only successfully treats 1 in 8 that it's not? I guess it comes back to, like you said, it's not. It's how they phrased it.
Yeah.
We can't infer what they're trying to pose as an issue.
Yes, I think that's right. So I say it's not. I think it's just not an issue you could have. You can have a discussion about mental illness, but there isn't a thing here to grip on.
Yeah.
I think it's just certainly
There's
just
nothing to get
statements
hold of. Yeah.
yeah, mental health's very important.
Yeah.
63.
I
Happiness.
love this one. Sorry, it's brilliant.
Okay. So, for those who don't have it in front of them, I work with young people, and so this reflects their priority following extensive work and discussion, which is happiness. As adults and health professionals, we refer to it as mental health or emotional well-being, but they frequently say the term they're comfortable with is happiness. Following several projects looking at the subject, they think mental and physical health are inseparable and feel there should be more invested in early intervention, education and awareness. Our young people would like a big discussion on happiness.
I want to go to that conversation.
That's fine. I mean, I personally, I think that buried in the happiness, there's actually a lot of interesting stuff around young people's
There's
mental
loads
health
of
and
stuff
joined
there.
up services.
And I think, again, we'll come to some, there's other issues that are posted later
Yeah.
that would fit in with this as a broad frame.
This is about providing services that work
Okay,
for people.
so if it goes
Yeah.
through, it goes through. Brilliant. 64. Access to services, audited application of NICE guidelines and best practice. My children are still not treated on any coherent pathway and suffer more at each illness and admission to hospital, which is avoidable if they were receiving the treatment they're supposed to.
This feels like a local.
Well, I think it's a kind of personal, it's a patient's
Yeah.
opinion,
Yeah.
personal experience thing, which may be revealing a problem, but we can't quite tell from the information here what that problem might be. So I think it's not really discussable. Early diagnosis. There should be more early diagnosis. Yes.
Yes, there
But-
Does this feed into the access then?
Yeah, I think it probably does actually.
Because it's about people picking up issues early on so they can address them.
Being educated about knowing where
Yeah.
to go and then being picked up and referred appropriately. Yeah.
Okay. Yeah.
Good.
So 66, access to high-cost drugs for rare diseases. Access to high-cost drugs for rare disease treatments which are emerging, such as Duchenne muscular dystrophy, and that the appropriate regulatory approval and funding is in place when such treatments become available. So, is this a NICE responsibility? Or is it, someone suggests further down it's a NICE responsibility?
I think it's nice.
Yeah, I suspect it is as well.
It is. It's about the information. So we talked earlier about just about the information only and whether it's how is information provided that people know it's the responsibility of NICE.
But it's also, so there's the nice bit of that process, but then there's the funding for that. So NICE say that that's a good treatment, whatever. But then if it's a rare disease, NHS England would be the commissioner for that. So therefore it's a financial decision as well.
Well, if it is something that we can talk about and it's worth
I
putting on the
think
agenda,
I think it's worth taking through
okay,
for
take
now.
it through, fine. Brilliant.
Yeah.
67. Non-surgical and drug-free solutions for those with knee problems. More research needed into non-surgical and drug-free solutions. I think that's not...
I don't think we can pick that up. I think I'm not going to disagree with it, but
Yeah.
I don't think it would fall to NHS England.
68. Homeopathy and other natural complementary medicines, giving patients choice in healthcare. It's been part of the NHS since its inception and Britain boasts some of the leading institutions and professionals in the field, many operating within the NHS. It's a long issue there that you can see online. NHS England issue? Or a nice issue?
Does this
Or
fall under personalised care? 'Cause it's about somebody choosing what form of, whether they receive a medical model or a natural remedy.
I don't think it's an NHS England issue. Because I think there's a nice thing, I think
Yeah.
there's a personalisation thing, I think there's a local CCG.
It's an access issue. It's about people getting the treatment that they want.
So the question about the NHS England issue is whether, if the NHS England board has a good discussion about it, it can make any difference. Because we don't want we've got 5 issues for the agenda. We don't want any of them to be interesting dinner table conversations that then don't lead to anything.
No.
So if the NHS England board had a discussion about this, could anything change? Or is it all really within the power of NICE and within the power of individual prescribing decisions,
Yeah,
etc.?
I don't think the power lies with the Board of NHS England to do anything with this.
I don't think it'll lead to any change. What the comment here is saying is that there's very good evidence that it is effective. So that is then an individual funding decision for that person's care, if they can use it or not. I don't think it's an issue that would be.
Yeah, for me, I think this isn't for the board. I think it's for something where you can pass it on to NICE, or you can pass it on to, think about in the conversation about personalised care and what people can buy with personalised care. But I think beyond that, the strategy of it is not for the board.
Mm-hmm.
Okay.
Yeah.
69.
Can I just make a comment on what's going on Twitter and say thank you to Jen Person, who's doing a phenomenal job of connecting stuff in and keeping people engaged in this conversation. Thanks, Jen. It's great.
Yeah, this is good.
Sorry.
Yes.
Okay.
No, that's good.
Sorry.
No, that's great, thank you. 200 people watching online, apparently.
Yeah, that just terrifies me. Can we not say that one?
No. 200 lovely people. Cap on gender reassignment surgery, 69. My surgeon was advised that my surgery is funded on, so it's an individual story, but is there a cap on gender reassignment surgery?
So I think this falls into the whatever number it was, specialised gender one, and the funding of, and we bundle those together.
Yes.
11. Yes.
Okay. 70, self-care. Prevention should be our vision. We say 50 million need to take self-care into our hearts. I won't read it through, but yes. So self-care, multi-system social approaches with education and training, tax incentives, grants and benefits.
So I think this goes back to page 10 and involving patients in the management of their own healthcare.
Yeah, 23.
Which we lump together, and that then comes through because they're all part of the same.
Yeah, that's the same. They're pretty much exactly the same. Yes, so 23. Okay. 71, evidence-based healthcare. Adults and children with idiopathic uveitis are being left to go blind needlessly because they don't have access to the biologic therapies those with diagnosed systemic autoimmune disease, which includes uveitis as a symptom receive. It's quite a specific issue, but is it nationally significant?
So I think I don't know enough about rare diseases and highly specialised services, but I think this falls into those, in which case we took one through the access to high cost drugs for rare diseases. Is that a bigger conversation about?
I think biologic therapies are basically, you can think of them in the same conversation as funding drugs, can't you?
Mm-hmm. It's access to support and therapies for rare diseases and specialised conditions, isn't it?
So is that how that whole thing gets badged then?
Yeah.
So that was page 38, top of 66, it's on the back.
66. Okay, yeah.
I think they go together.
I think that's right.
Colleagues in specialised services can correct me.
So next one's not quite the same because it's about research. So there's a need for more resources on research into difficult cancers such as pancreas. Is research in NHS England a thing?
Yes, in terms of we support it and commission it. However, it's one of the other bodies, the name of which is now going to escape me. Who does research? What are they called? Somebody help. Sorry, head blank.
Okay.
I don't think it is an NHS England within the gift of NHS England to pick this one up. It's whoever the other one is with the support of NHS England.
Okay, so that Health Research Authority.
Is that what they're called? It's something like that.
When you search NHS research funding, that's what it comes up. Or National Institute for Health Research.
National Institute, thank you.
So we pass it on to them.
Yeah.
Okay. 73. Parity of esteem for mental health. Plenty of fine words, but this has been undermined by cuts in funding and lack of progress in delivering this legal obligation, particularly for severe and enduring mental illness and those needing secondary care. How will the NHS and CCGs help, I think, rather than CCGs to meet their legal obligations? How will standards be raised across mental health to meet best practice across services?
I think it's definitely an issue to go
Feels
forward.
like it, so go
Yeah.
on for me.
Definitely.
So,
Have we got rid of money yet?
sorry?
Have we got rid of
We've got-
money yet?
So we have more than you think. We've grouped quite a lot.
Okay.
I imagine, I don't know whether Susie or Mel have been kind of keeping tabs on what we've been doing, but I think we've probably got about 10 groups, Huda?
But we need to go back and
Yeah.
Yeah. So I think we get through these last 6 and we take a 5-minute break and just
Yeah.
and make that happen.
I'll have a bit of a regroup. Okay.
Yeah. Okay. 74. Hyperparathyroidism.
Can I
Should be a
say?
discussion topic.
Yeah, it's also difficult to say as well as diagnose. So there's loads of comments about this. I think this has got more comments than any other
Not much.
one.
I think they all came in quite late. I think this is a. Oh, I see. So they were all individual issues that were grouped. Ah, right.
Crikey.
Wow.
Well then.
Yeah, I just think it's an astonishing number of comments.
But is it a nationally significant issue? Is it an NHS England issue? I mean, because one of the problems is one of the issues that you have here is there's multiple recommendations in these issues.
Yeah.
So but some is education, some is funding blood tests, some is more research, some is
And all these from separate people? Or are they from...
Yes, they all came into the where people could suggest issues for discussions. They all came to there, so they all went as one discussion point on the.
But they were all submitted for separate people. Okay, so this is really complicated. I don't think it's a specific NHS England issue.
Mhm.
I think it cuts across specialised and CCG commission services. I think it cuts across education and training. I think we absolutely have to make sure that we pick it up and take it somewhere. And I wonder if there's something that we can say that we'll try and pick it up and have a separate conversation outside of the Assembly, because it's so complex and complicated
yeah, it does feel that way.
and clinically
So many
technical,
different issues.
and there's so many different issues that are all within there.
So
But the strength of the evidence in terms of everything that the number of people that have submitted all of those things, I mean, we're not going to ignore any issues that are posted, but I think we need to recognise the significance of this.
okay. So we'll take it.
So
We'll take it away for a separate
We'll talk to
conversation.
some colleagues in NHS England in specialised services about what we do with all of that
Okay.
and how we can contact people who posted them as well,
Yeah,
can't we?
quite a few people have said that they're willing to come and talk about it. So
Yeah.
Okay. 75.
Does that sound fair?
I think it sounds reasonable because it does seem like it's quite a technical issue, and although it may be of national significance if it's if it's as widespread as some of the comments suggested it is, then actually, if it's a very technical issue, I'm not sure the board themselves are the right place to have that discussion, or the
Okay.
right people to have that discussion, because I think you get
Yeah.
quite generally supportive answers, which is good, but that's not necessarily the same as having an action plan.
Cool. Okay.
75. Youth involvement in policy development. I'm not going to read the very long comment from Mentor UK, but young people should be involved in NHS policy development, and NHS England should make it a priority to involve young people in discussions and developments of policies. We had a general point about participation earlier on.
Yeah,
Does this group with that?
I think it does, and I think the young people stuff gets picked up better on some of the issue-specific things.
Mm-hmm.
And it's an interesting one because actually we've got the NHS England Youth Forum, who are actively having some of the conversations around some of these issues as well, and will be at the Assembly session. So to some degree, I don't want to say we're already doing that. We've made a start on making sure that we involve young people, and we specifically made sure that in allocating places to the Assembly session itself that we aim to try and get a minimum of 20% of young people at the Assembly. So
I think one of the things looking down 76, 77, 78, 79, 80, the last ones, is there is just a kind of general children and young people's healthcare block. None of them are very specific. None of them are saying this is about this, and none of them are as specific as the hyperparathyroidism.
no,
But
but they're specific in terms of
there's
mental
one on
health,
mental health, one on
and
sexual
health.
health, which I think may be the things that
Yeah.
I think engagement, mental health, and sexual health are the three that are coming up from this. Whether we say there's a young people's group issue that has special reference to those two, or whether we put young people into the mental health conversation, young people's strand into the mental health conversation.
Yeah. So actually, there's a significant point in this that we got feedback at last year's AGM from a young person who attended from Brooke, who wrote a blog about it. It's on the Brooke website, about how she didn't necessarily feel listened to by the other participants in that. She was listened to by the facilitator, but the participants that were in the same group as her didn't necessarily work with her as an equal. So her feedback was actually some space for young people to talk about young people's issues would have been really good. And I think there is an interesting balance of, do we have young people integrated into a mental health discussion, or do we have a young people's discussion about mental health? And I think there's merits in both.
Absolutely.
What do you think? What's our best approach with these last six? Because they're so similar, you can't really say, well, we'll have mental health, but not sexual health, or vice versa. But the question is whether it's it feels like you can't not talk about at least one or two of these issues. It's just a question
Mental
of
health
in what
was the
form.
focus of the Youth Forum's meeting in
Yeah.
July. So whether things have... What the direction has been picked up from that.
And so the Youth Forum's priorities, I won't remember all of them, but are communication, sexual health, mental health.
And provision of services.
Access.
A range of services.
Yeah.
So part of me is tempted to say, actually, we should take that as a question back to the Youth Forum. We don't necessarily have the time to do that. But could we make space in the Assembly so that we make sure we have a young people's voice within a mental health conversation, but also space for young people to talk about all of those issues as young people?
Are the Youth Forum intending to bring some of the issues that they raised from the July meeting?
They would bring the evidence that they've got in terms of the work they've done thus far. Yeah.
I feel like the solution for now is that we say yes to a group around 75, and we work out exactly what the question is when we come back to the mental health conversation from earlier.
Okay. Yeah.
Right. In which case, that's all of the issues filtered. I think it's worth taking a break.
Ooh.
But I
It's a
think
hard hour, unfortunately.
it's hard, and I think one of the things that comes up from it, I don't know whether the listeners would wish to comment on it, but one of the things that comes up is that there are groups of issues coming out quite strongly. But is that the right? Is grouping those issues the way to get a conversation that's not too broad?
So if we'd have had more time online in the gather space, would we have ended up with these issues starting to naturally cluster and group, with people connecting those conversations?
I'm not sure. I think the next phase of refinement maybe, or a phase like that
Yeah.
might be.
Big break. Gail, what did you want to write?
I have,
back in
yes.
10 minutes.
And the
10 minutes.
That was it, isn't it?
Okay. It's like shot from.
yes.
Got that? I remember them on the we're sitting here. So.
We're on, folks.
Hello.
Okay, so while we've been away, Huda has been tirelessly going through the questions and working out which ones we grouped with which other ones, and also which ones we wanted to come back to. So, the one we wanted to come back to, in fact the only one we said we wanted to come back to was 5, which was community cohesion, asset-based community development. So just to remind people, it was the ABCD model, asset-based community development, is the way forward for public and patient engagement in communities, including rural, seeing people's assets as well as vulnerabilities. Money will be spent more appropriately and reduce pigeonholing service provision. So, given the other groups that we've come up with, or given the other issues that we've grouped together, which are around things like young people, mental health, access, is there something about communities and participation here, or is this is there a communities issue and a participation issue, or is this it feels like this is definitely through the filter. It feels like this is a national issue, nationally significant, or NHS England issue, nationally significant, and that you could discuss it. I think just to make sure that we are happy that it is, are we saying it ought to be better in one of those groups, or is it better as an issue on its own?
We did link it with another issue in here around the involvement of third sector in NHS delivery.
Yeah.
And we also linked it to the participation and involvement.
Yes, we did. Which was...
It was the first one, the young people.
Sorry, Zoe.
The young people issues are all at the back, but something up
No,
in the
there was
people.
Page 12. Involvement of
Yeah. So we grouped together 24 to 27,
Yeah.
which were all about involvement, and we could put the ABCD one into that. If we're seeing citizens and communities as those assets in terms of informing, involving and influencing, then there would be a natural fit.
Seems to make sense to me. So
Okay.
we group this with 24.
24
Number
to
5 groups with
27,
24
yeah.
to 27. Right.
Yeah. And that would then draw in as well the one on page 25. But I don't know which number it is.
40, which is peer support, or
Involvement of third
41, which is
sector
third sector.
Involvement of third sector in delivery.
Okay.
Yeah.
Okay. So I think what we're saying then, just to be clear, that there is a group around access to primary care, or access to all sorts of care.
I think it's access to health and care, isn't it? Which
Yeah.
is it's people don't distinguish between primary and community care, really, do they?
No.
As a citizen, I don't.
No. Well, no. I mean, most
No,
people.
and that's
most
come
people
through
don't.
in this
Yeah.
as well, that there's no distinction made.
There's a group around involvement, which the core of which is 24 to 27.
Yeah.
There's a group around specialised services, developing funding, data on, etc.
Yeah,
is-
but that is using gender identity services as the specific,
Gender identity.
because actually the gender services are the only specific one that's been mentioned in relation to specialised.
There's a general funding one, which was 17.
Yeah.
And I suppose under that you could even draw in some of the issues around service provision models and things like that.
Yeah.
Yeah.
We said we would put through training patients and public to be effective lay representatives. That was
But
18.
that comes into the involvement one then, doesn't it?
Yes, that's true.
Yeah.
So 18 isn't there. There's patient records and data. which includes care.data.
Yeah.
Self-care and self-management was one group.
Yeah. So I think that's the sort of the personalisation, self-care, self-management.
Personalisation. Okay.
Yeah.
Is that the same as the question on choice versus safety? Yeah, people
No.
make the assumption that we choose, but actually choice is a false
So I think
choice.
that goes into the access one.
Okay.
Because the point being made in that one is that choice, you need to be informed and able to make a choice. Therefore, actually, what we don't actually have choice at the moment. It's a bit artificial.
Okay, I'm just trying to make sure that we've got all of the ones that we said we'd go through. So joined up thinking goes into personalisation.
The peer support one, are we happy to put in with the personalisation, self-care and support?
Yes.
Yeah?
Yeah.
Equality in NHS workforce and leadership is one that doesn't. Is that separate?
That's definitely a separate, isn't it?
Yeah.
And does the customer service issue come into that as well?
No, this one's specifically about diversity, I think. Genomics, separate
Yeah.
issue. Peer support, is that part of involvement?
No, we've just put that into
Self-care,
personalisation,
management.
self-care and support.
Oh, sorry.
Yeah.
Patient data is in the data section.
Yeah.
Equalities is the central issue. Equality central to decision making. Is that a... Where does that go?
What number's that?
48.
Sorry, what
First
page?
issue on page 29.
I think that's the equality and diversity one around workforce diversity as well.
So it's a, you
I think it
it's-
comes into the equality and diversity one.
Okay.
Yeah.
Right. Urgent and emergency care is an access one.
Yeah.
Accessible ICT for all. So this is training people.
Sorry, hang on, just go back to communication.
Yep.
Is that a specific one?
We
had
said we were going to group it with 3 with
49,
access.
34. Okay,
Yeah.
no, that's fine.
Or we could have a separate communication. I mean, access is slightly different from communication, to be fair.
I think it is different because it also then brings in the customer service.
Yeah. Yeah, absolutely.
Yeah.
Okay. Urgent and emergency care, which is then...
I think that's access.
Okay.
Do I think that's...
I think it's communications, isn't it? What could the NHS do to help citizens decide? I think that's
Oh, sorry.
where is the best place to go to address urgent and emergency care? I think that's actually a communications one.
thing. Yeah, okay.
Okay. So ICT training for patients, communications as well, or involvement, or peer support, or self-care.
All of those.
Okay, that's very helpful.
No, I know.
I'm going to put it under self-care because I think it is actually about you
I
taking
think,
your own
yeah.
responsibilities and having the
That's fine.
skills and knowledge to do that.
Yeah.
54, headline data is under data, that's nice and easy. Health literacy, reading and writing, people don't turn up for appointments.
So I
that's-
think that actually needs to go into the communication one and the self-care one. You know, we mentioned it actually could be a cross-cutting theme.
Yeah. Possibly access as well.
Yeah.
Okay. How can NHS England support carers better? Is there a separate
Carers
carers?
is a separate one.
Dealing with obesity, separate.
Yeah, it's not falling into any of the others specifically, is it?
Okay.
Happiness.
Happiness. Is that self-care and personalisation, do you think?
It's more mental health,
Okay.
which we haven't got to yet.
All right. So we'll create that. Early diagnosis is an access issue, we think, or we thought.
Yes.
Access to high-cost drugs for rare diseases. Is that an access issue as well? Or is it a... We put it through rare disease treatments which are emerging, such as Duchenne muscular dystrophy.
And we linked it with 66.
Yes. Oh, no, that was 66.
Oh, was it? Sorry.
Yeah.
It feels separate.
I think it's a nice thing, personally. Do we still think it goes ahead? I still feel like anything that's to do with funding is fundamental. Yeah, with access to high cost drugs must surely be a nice issue fundamentally. I feel like if you put it to the Assembly, you get some interesting views, but the board in particular would feel they were unable to say anything useful because they'd be treading on nice's toes. But I might be wrong. What do you think, Sasha?
Wasn't the issue more about how do we decide new models of... If there's funding, then I don't think we'd get the rich discussion.
See, I think if you look at the discussion that was online, it was all about nice. So I think it's a nice issue, not an NHS citizen one, an NHS England one.
Okay, it's a nice issue. Yeah.
Okay. Gender reassignment surgery cap.
We've
said
linked
it's part
back
of
with
specialists.
specialised.
Self-care we already have an item for.
Yeah.
Evidence-based healthcare and commissioning of therapies.
That was the one we linked with 66.
Oh, that was we linked. So yes, actually, this was the better expressed point about rare diseases. So I think maybe this is is it. Is it a rare diseases issue? Or are we saying actually if the previous one was a nice issue, this one's fundamentally a nice issue as well?
That's what we said before.
I think it's, if we're saying it's a nice issue, then that one goes back with that too.
And, I think it's important to say that doesn't mean it's disappearing into the memory hole. It's going to nice, because they're the best placed people to answer it rather than... this isn't qualification for, as I always say, the World Cup finals. Right, parity of esteem is mental health.
Does that go, and the happiness.
Hyperthyroidism is ruled out. Young people. So young people, where do we end up with on this?
So this was whether we had a separate conversation around young people or whether it was threaded through services. So, for example, with carers, do we then also look at young carers? Communication, how do we communicate with young people?
I think they have to be a theme in all of these that are relevant.
Yes, I can see that point. I guess the question is, does it then get subsumed into yes and young people? Is it worth saying that actually the number of issues that came up and the way in which they were expressed was specifically about how those services are used and experienced by those people? And that if we say it's carers, don't forget about the young people, it becomes a discussion about carers, maybe with some conversations about young people as well. But actually, it's one of those things where which is more important, the horizontal or the vertical?
Yeah.
If we're going on what issues were raised here, then the issues raised here were mental health, sexual health and involvement.
Yes.
And young carers didn't come up, so you would...
So we could certainly say mental health and involvement, but not sexual health. So involvement and mental health came up elsewhere, so you could say, oh, well, the young people, this issue goes in there. Sexual health is new.
There's a generic one around the focus on children and young people's healthcare.
Yeah.
Because there's that first one about maternity as well.
Yeah, there is.
Yeah.
Maternity and children's services.
In the community.
So, actually, does that become the discussion?
Yeah. With the young people's questions on mental health and involvement going elsewhere. Yeah, I think that's a reasonable.
And we highlight
grouping.
and flag with the youth forum.
Yeah.
All of these as well, because it fits with their ongoing
Yeah.
work programme as a forum through which young people are actively involved in those conversations.
Yeah.
Yeah?
Yes, I think that's right.
Okay. That works for me, I think. If
Okay.
Kath Evans is on Twitter, maybe she wants to make a comment about that.
Right. So that gives us 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 issues. 13 groups of issues, each of which has one or more of the issues raised on Gather associated with it. And just to run through the list, for those who haven't been playing along at home, access is the first one.
Yeah.
Involvement,
Yeah.
gender identity, and as an example of a specialised service.
Yeah.
Funding, patient records and data, self-care and personalisation, equality and diversity, genomics, communication, mental health, carers, obesity, and young people. And the young people group, there were some young people questions that were referred to elsewhere.
So I've got 13, is that right?
Yeah.
Yeah. Okay.
So, if we go back to the criteria that we started from, is issues that have had good quality discussions in the Gather space. Now, in terms of the demand for these topics to be talked about, I think it's worth saying that of those, 1, 2, 3, 4 only have one, come from just one single issue raised, whereas the others are all multiple issues that were raised. So funding, or obviously a huge issue, was only raised once. Genomics, ditto, always only raised once. Obesity, only raised once. Carers, only raised once. So if you're saying number of times people raised it as a separate issue, as one of the proxies for how well discussed it was, those are the less well discussed.
Yeah.
Now, that's not to say they're the less important, but it's just, if we are starting from the Gather space, that's where you do your first cut.
Yep.
Now, we've got to get down to 5, and which is going to be hard, I think. But if you order it from number of questions raised, then the lowest is carers, obesity, genomics, and funding.
Yep.
The next lowest is gender identity, specialised services, equality, and diversity. Then you kind of get into areas where there's multiple questions. I suppose mental health is the one that kind of then is the one that only has 3. Patient records and data and communication have 4 each. So if you were just going on the basis of numbers of issues, you'd actually have 6. You'd have access, you'd have involvement, you'd have self-care and personalisation, you'd have patient records and data, you'd have how the NHS communicates, and you'd have young people, because patient records and data and communications would have been tied on 4. That's not the only criterion. We also have to look at whether the scale of the issue is known, so we can understand it as an issue, whether people are going to be able to express different views on the topic, whether it's not just something that everyone would agree with, whether you can have open questions rather than closed ones, whether the discussions themselves, I think, weren't on all of those so detailed that you could realistically judge them against these quality criteria. But I think, you could say, could you bring evidence on it? Could you create solutions and ideas from it? Could you create open questions rather than closed ones on all of those issues? So I think we're going to have to say, I don't know, it seems like
It's a
tricky
difficult one because
one.
there's things there that haven't got many mentions.
Yeah,
It's not a popularity contest.
but it isn't a popularity contest.
So, does more mentions or more interest?
See, this is the core problem that any citizen's jury dealing with these sorts of issues is going to have to come up against, which is how can it without imposing its own judgment, without saying that's more interesting than this, how can it come up with something that reflects what the discussion's been? Because if we just looked at the discussion, if you were to walk out here in Brighton onto the streets, and say, what's the most important issue about the NHS to someone, they would probably say funding. And maybe they'd say privatisation, or maybe they'd not. But funding will be in there. And so to say, well, only one person raised funding, so therefore people don't think it's that important, is obviously not true.
Yeah.
But at the same time, if we include funding, then either patient involvement, self-care, how the NHS communicates, young people are going to be dropping off instead. Which, given that those were the things that people were actually interested in talking about of the people who involved themselves, is a
the other thing
bit of a hard cut.
Is where can influence be made?
Yes, that's
because
true.
you want people on the day to actually know that their input is going to lead to some change. And is there something, for example, taking funding, is that something that actually people might not be able to have an influence on? So to have a discussion about that, which then leads to nothing, could be disempowering.
Yeah, it's certainly true. Certainly, I can see that. Yeah, certainly you can see on funding that you're going to get to a set of statements that people are just going to make. It's going to be a set of statements, and not necessarily change.
Yes, and the funding was an interesting one, isn't it? So if we did the access question and the model of NHS care and how we access it, when we access it, where we access it, actually that's the conversation to have as opposed to the funding conversation, because until we've remodelled it, you don't therefore know what it's going to cost. So the two are very interrelated. I don't think I said that very well. But
No, I understand. I understand the point. So, it feels to me like we are saying, actually, of these 13 issues, the starting point is usefully the number of times that people are raising it and talking about it.
I think we could usefully get rid of those which we haven't been grouped, they've just been a single issue that's been... So genomics is a specific one, it's been mentioned by posted by one person, there's been no discussion on it.
Yeah. So then the question is, are there issues where we are basically going to have the same conversation under two different headings? So currently we have access, involvement, specialised services using gender identity as an example, equality and diversity, self-care and personalisation, patient records and data, how the NHS communicates, mental health and young people. Now for me, how the NHS communicates is something that maybe is the one that's most easily...
it runs through everything.
Yeah, exactly. It feels like communications is a conversation you can't have alone. Can't have on its own. It has to be communications about something.
Yeah.
So therefore, that feels to me like something you would be better off distributing the 4 questions that we identified as going through into other areas where they're relevant, and kind of saying this is an underlying issue that came out, but not an issue that you want to discuss.
So it's something that
becomes
all
a
five
cross-cutting
of them address the issue of how they're going to communicate those messages. And yes.
Okay, so that brings us down to 1, 2, 3, 4, 5, 6, 7, 8 issues. So we currently are at access, which is access to services. How can we make it? Now, does equality and diversity and access cover the same ground?
No, because that was about workforce.
One of them was about workforce, but the other one was about equality should be at the centre of everything the NHS does.
Which included the workforce reflection of what that actually means in practice.
Okay, but how much is NHS England responsible for workforce?
Its own workforce, enormously.
But the workforce of the NHS as a whole?
Not.
Each NHS organisation is responsible for its own workforce.
But NHS England convenes and leads the Equality and Diversity Council on behalf of the system. Therefore, there's a leadership role around equality and diversity that's really important.
and it's an issue that's constantly been there for a long time. And is there something about having an open discussion with citizens as to looking at a way forward?
Or is it Groundhog Day, where we have the same conversation that's had in many, many places?
My view, and you shoot me down if you think I'm wrong, my view is that equality and diversity, when it comes to access, is an access. When it comes to workforce, it's not for NHS England to make a comment on. Well, to comment on fine, but not to do anything about.
No, I think there's a role around the training, which came up somewhere else. There's something around how we work with education, the health information. All of those systems work together to address this, and it's not. Then it comes back to our qualifying criteria. It's not purely within NHS England's remit when you look at that wider picture of how do you make the workforce representative.
Yeah.
Which is what one of the questions were.
Mm-hmm.
So do we move 48, the equality at the centre of everything the NHS does, to an access, an underlying issue like communications? So you say that several of these issues are to do with equalities.
I think it's an underlying issue as well.
Yeah.
It's a question for everyone to reflect on: is how in providing access, involvement, how are they ensuring that there's a representation of views, and
so it becomes a cross-cutting consideration for all, in the same way we're saying that about communication.
Yeah.
Yeah?
Yeah, I think that's
Okay.
right. Okay.
which actually makes it quite powerful to select the communications that all 5 panels respond to those challenges.
Mm-hmm.
So does then, so again, could be wrong. Do involvement and young people work in the same way? Because would you be able to say that the issues are access, patient records and data, self-care and personalisation, specialised services using gender identity, an example, and mental health, in the context of communications, involvement, equality and diversity in young people?
I think with young people there are certain services that require a completely different configuration, which makes it a different
Separate issue.
issue.
Yeah, so children and young people's services is very different.
Okay.
So that, but if we took that, so not for young people, but if we took that approach for involvement,
Yeah.
that would work, I think.
Yeah.
Yeah.
So that brings you down to 1, 2, 3, 4, 5, 6 issues. Which is the issue you don't want.
I don't like this. Can we stop this now? I don't want to do this anymore, please. Thank you very much. Oh.
So the 6 issues are then access, gender identity, patient records and data, self-care and personalisation, mental health and young people.
So, probably where my personal prejudices start to come in. On the data one and patient records, is there an argument that says we're already doing a lot of engagements and involvements around care.data, that patient records access isn't just an NHS England issue, it's a provider issue.
Mm-hmm.
There's a commitment you have to have access to your record online by April next year. That's already a given. So it's an operational issue about how we make that happen. So does that then become a lower priority because stuff's already in train to address the issues being raised?
And it's also what influence can be made on the day.
Yeah. What difference will there be as a result of another conversation about those things?
Okay, that's the stronger point for me, because if we look at it just in terms of what people are interested in,
Yeah.
specialised services and gender identity people were less interested in terms of the number of issues raised, but it's not a numbers game, because those are, in fact, gender identity is the classic example of the small number of people big issue.
Yeah.
As opposed to patient record and data, which is lots of people not small issue, but lots of people a little bit, rather than a small number of people a lot.
Yeah.
Well, I don't know. What do you think, Sasha?
Don't look at me. What's critical?
Twitter thinks
yeah.
Twitter thinks nothing. This is a citizens' jury. In a real environment, Twitter would not be in the room.
Wouldn't it?
Probably. Well, it would depend on how isolated you want the process to be, how much you want it to be just on the basis of what's in the room. A standard, citizens' jury would not have external
But they're
factors.
not standard.
No, that's true.
We're creating something new.
Well, I think this one
so
of the
I
things.
challenge you as to why we wouldn't have that.
I think the question is, this is kind of going off piste a bit, but I think the question is, if you have, what is this part of the process for? What we're doing here, and I think it's the right thing to do in this circumstance, is we are trying to get the maximum content and quality out of the discussion that's happened so far on the issues that have been raised up to the AGM and the Assembly, but by as far as possible shoehorning things in, not warping them out of shape, but pushing things in to make sure that as many issues as possible get covered, rather than doing a kind of very sort of black and white, right, 5 issues, 5 individual questions from Gather, and 75 out, 5 in, 75 out. What we've got here is probably 20 to 30 in, and 50 to 60 out, which is still quite a lot of sorting. But you're kind of creating groups of issues that feel right. If you were doing it, if that's the way we want to do it in the future, then actually it becomes much more of a gathering conversation and a pushing together conversation, rather than a standard citizens' jury in, out, in, out, in. And it's just a question for the next time we do this. I think this produces good issues. I think the question is whether it produces issues, and we won't find out till the AGM, whether it produces issues that are so broad that you get conversations that are just kind of skimming the surface rather than going into depth. Personally, I think the balance is about right, but then I've been involved in the process, so I would. What do we think? Because I think the choices are.
Can we start from the other side and say the ones we think should definitely be in?
Yeah.
Is that
I think yes. Okay. Well, if I had 2 that I would definitely say you can't not have in, I would say you'd have access and you'd have self-care and personalisation.
Yeah, I agree. I'd also
put mental health.
Okay. So that means that of the 3 that are left, young people, patient records and data, and specialised services, we have to choose one. That doesn't make the cut. No.
Oh, one that doesn't make the cut. Sorry, yes.
So I think that of those 3, the order I would put those 3 in is probably young people, gender identity, patient records and data. But that's just a personal view.
So I think we should definitely have young people's healthcare in.
Okay.
22% of the population off got.
Then we're back to patient records and data or specialist services.
And what's the conversation about specialised services that we're having?
That's the gender. Basically, it would be a gender identity conversation about how it's resourced and how it's delivered as a specialised service and what's done locally.
So is that something that there will be some influence and change that would happen?
So can I just make one point, which is very much from a process test point of view. Given that the AGM is meant to be a test of the NHS citizen process, I quite want gender identity in there because I want to test how an issue that affects a very small number of people can be handled in a big process like the Assembly. Because actually, if we put something that everyone is involved in some way, well, that's not very challenging. If we get an audience of 95% cis people to have a conversation about gender identity and transgender issues in the NHS, that's a test of the system.
Yeah.
And it's an important test because it'll be something that people have no necessarily no experience or learning about. But there's a big conversation to be had.
I think that's quite a good rationale actually, because it would also give us one of the 5 issues. It would give us one that is quite niche, for want of a better expression,
Yeah.
whereas the others are much broader. So we get the test of both.
Yeah.
And there is the question about specialised services as a general as well,
Yeah.
for people who, on the day, who might not feel that they could contribute to a conversation on a certain specific topic, but actually there's a wider issue about funding for specialised services or access to them, and how the data was presented. Because that was another issue that was up there. So how do we share performance data on specialised services?
And how do mainstream NHS services provide services to people who also access specialised
So
services?
services, because that was another thing around mental health support for people.
So trans people should get a high quality service from any GP that's relevant to their healthcare needs, as opposed to just being pigeonholed into a specialised over there.
Yeah.
I can go with that as a set of logic, which would mean that we don't then do data and patient records.
But it may be better to, I mean, I don't know, you can't really hold things over, but I do think it would be worth saying this once the care.data stuff has worked its way through, the next assembly ought to think about this. Yeah, it feels to me like something you could say.
We could, and actually timing-wise, we could say that. So if the patient record access commitment is actually by April 2016, sorry, 2015, you should have access online to your healthcare record. If we've then got an assembly session in April, it would be an interesting conversation to have around how many practices have turned on that ability.
And it would be a more real conversation than this is going to happen. It's
Okay.
what's happening.
Yeah.
So, I think we should all three do some reflections on what this process felt like for us. Are we happy then that the issues are access to services, gender identity as an exemplar of specialist services, self-care and personalisation, mental health, and young people?
Young people's healthcare.
Young people's healthcare.
Yeah. Yes.
Yes?
Yeah.
Yeah.
With underlying themes of
With
communication,
underlying things of communication, involvement, and equality and diversity. And I think we need to go to Sir Simon, who's running the assembly part of the process test, to say, well, how would you handle those three undercutting themes?
Yeah.
And do we ask NHS England to provide a general brief for participants on those three underlying themes? Okay, I'm happy with that.
That.
Could you just read that again, just so we can quite get them all down? And
Okay, Susie, it was access to services.
That's quite. I think it's important we remember that's actually quite a big, chunky one. That isn't. It's not just access. It's access and where. So the primary community conversation and the remodelling.
So access to primary care and where people enter the system.
Yes.
Yeah.
Second one was gender identity. Third one was self-care and personalisation. The fourth one was mental health. And the fifth one was young people's healthcare. And the way that I will phrase these, I'll write this up now, is to say this was the overall issue, which came from these issues. A summary came from these issues raised, and try to summarise the often quite long questions that were raised on the gather space into a sort of set of bullet points that was this is why this came up. The next step is we're then going to ask people who were participating to give us their kind of final thoughts, their closing statements, as it were, which people can kind of vote in support of, so that we can get a sense of what people's prioritised outcomes are for this. And that's something that will be up in the next few days, and next couple of days. So there'll be about a week of doing that, so that people can come up with things. And it may be that people are just happy with what was there on the gather space already. They don't want to add anything, which is fine. But if they do, they've got the chance to kind of come back into the discussion, and we'll notify everyone who was part of the discussion already to say you've got your second chance now to, now that you know these are the issues that are going to the Assembly,
Yeah.
this is the moment that you can pitch in.
So then the other piece, the other side of that is we then need to take those issues with the discussions to colleagues who have relevant responsibilities within NHS England
Yeah.
and engaging them in those conversations
Yes.
and
Exactly.
collating together some of the evidence for the evidence packs.
Okay.
Okay. It's exciting.
Right. Thank you very much, and thank you to those who've been watching. We did it with 9 minutes to spare.
Difficult, really.
It was very difficult, and we'll write up our reflections, including the people in the room, on how difficult it was
Yeah.
to take into the next design phase. Thank you.
Thank you. Thanks for watching.